Hi, this is Professor Erica Jones, and today we're going to learn about respiratory problems, starting with COPD, which is also known as chronic obstructive pulmonary disease. Our objectives for today's class are for you to understand what's going on with patients who have COPD, the significance of tobacco use, smoking in COPD, what a patient with COPD looks like, what studies are used and how these patients are managed. And we're going to talk about the nursing process and implementing nursing care plans for patients who have COPD. To start with, let's look at your normal lung structures and how they function. The lungs are very open. I kind of try and describe them like a sponge that hasn't been soaked in water. So they are very flexible. They should be very strong. The trachea and bronchus are open. They're lined with cilia and protective mucus to help keep dust and other contaminants out. And the cilia are very active. They're always pushing foreign things out of the airways. The alveoli deeper down in the lungs expand and oxygenate your venous blood for distribution to the body. So those alveoli, like a sponge, you want them open and you want the whole lung to be flexible. So what happens when a patient has COPD? The patients experience a limitation in their airflow, which is not fully reversible. It's generally a progressive disorder. It's related to an abnormal inflammatory process. We're not really sure the exact pathology of how COPD develops, but it's partly because of noxious particles or gases, and we'll talk about that when we talk about smoking. It includes the constellation of chronic bronchitis and emphysema. It used to be that you would talk about COPD as a combination of those two things, and it's no longer separated just because it's hard to diagnose which is contributing more to patients who have COPD. Just understand that oftentimes COPD, because it's an obstructive disease, their lungs are not flexible like a healthy person's lungs, and they can't expire completely. And we'll talk about that in the next few slides. Asthma is also included in this constellation of symptoms, but we're not really sure the exact contribution that asthma has to COPD. It's a separate diagnosis. So how common is COPD? It's extremely common. It's the third leading cause of death in the US. It kills more than 120,000 Americans every year, and ethnicity, people who are white and who are American, more white Americans die from COPD than any other ethnic group. So, speaking of white Americans, this is my grandma. She had COPD. She was a half a pack a day smoker for probably about 10 years, but she lived with my grandpa, who was a heavy smoker. He was probably a 2-pack a day smoker for his whole life. So she was exposed to significant amounts of cigarette smoke. She also may have had a genetic predisposition to COPD because her mother, she remembers her mother as being frequently out of breath. So there may have been a genetic element involved, which we'll talk about a little bit further on. But this is my grandma with my nephew Aiden, and this was probably 3 years before this picture here with my nephew Ethan, who was just born when this picture was taken. And you can see the pretty rapid progression of her disease. She went from not needing oxygen to being oxygen dependent, and she was pretty much limited by her breathing in the last, I want to say, 6 months to a year of her life. But she was just a wonderful person, and we'll talk a little bit about like the different effects of COPD kind of as related to my grandma, because this was my personal experience with the disease. So why do people get COPD? We talked about cigarette smoking is probably the #1 cause of COPD. If you are a smoker, if you have smokers in your household, if you know people that smoke, it is the number one thing that you or they can do to improve their health now. So if you smoke, I'm serious, email me. I'll be happy to give you information on QuitWorks and the different programs that are available in Massachusetts should you want to quit smoking. Despite cigarette smoking, other causes of COPD include occupational chemicals and dust. Air pollution plays a role as well. Infection, especially people that have chronic lung infections, can end up with COPD. And heredity, as I kind of mentioned with my grandma's case, the alpha antitrypsin antibody is sometimes involved in patients with COPD. This is a protein that's responsible for the protective lining in the lungs, and we'll talk about that a little bit more in the next few slides. And aging also plays a part. Our lungs, as we age, get less and less elastic and can lead to air trapping and the different pathology that we see in patients with COPD. And this gentleman in the picture, what's he doing? Smoking while he's on oxygen. Do you see that in clinical practice? Yes, you do. Not so much now that many hospitals and facilities are smoke-free, but this used to be a common occurrence. And is it recommended? No, it's never recommended because it's very dangerous because oxygen is highly flammable. So, clinically significant airway obstruction develops in 15% of smokers, but 80 to 90% of COPD deaths are related to tobacco smoking. And not only the smoke and the noxious particles from the cigarettes, but the nicotine is extremely powerful. It's an extremely powerful vasoconstrictor. It stimulates the sympathetic nervous system. It's going to raise your heart rate. It causes peripheral vasoconstriction. It clamps those veins down and makes it difficult for the oxygenated blood to get to the periphery of your body. And it increases your blood pressure as well as the workload of the heart. So nicotine, super powerful drug. For anybody who's never been a smoker, I can tell you I smoked for a short period of time and it was extremely difficult to quit just because nicotine is one of those drugs that you feel normal after you take it. So for those of you who are struggling to quit smoking, it's very common. It's an extremely powerful drug. One of the things that we're seeing more of is people that are vaping who are taking in higher percentages of nicotine are having a really difficult time quitting because they're exposed to so much nicotine. Not only that, but I've heard anecdotal stories about people who vape and wake up in the middle of the night to have like a hit off their vape because they're so addicted to nicotine. So we're going to talk a little bit about how powerful it is and how important it is that we protect our kids from getting addicted to nicotine at young ages. Other effects of cigarette smoking. Cigarette smoke contains carbon monoxide, which will decrease the blood's ability to carry oxygen. It increases your heart rate, and it impairs psychomotor performance and judgment. And passive smoking, secondhand smoke, also known as like side stream smoke, environmental tobacco smoke, for example, people that work in bars or restaurants where smoking is still allowed, that also can decrease your pulmonary function and it increases your risk of lung cancer and your respiratory symptoms. I really think that my grandma's COPD was largely related to the heavy secondhand smoke she was exposed to. So nicotine, not only does it powerfully vasoconstrict your blood vessels and increase your heart rate, it also decreases the amount of functional hemoglobin. And as you know, hemoglobin is the molecule in blood that carries oxygen. It'll increase your platelet aggregation, so it'll make you more at risk for having a blood clot, a stroke, or a heart attack. It compounds problems in people who have existing coronary artery disease. That powerful vasoconstrictor effect and the fact that it increases your cardiac workload is not good for anyone who has any cardiac issues. It also has effects on the respiratory tract. It causes hyperplasia of the goblet cells, and goblet cells are responsible for creating that nice thin mucus that lines our airways and protects us from contaminants. When the goblet cells are enlarged, it increases production of mucus. So, those patients with COPD that are coughing, 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 and they have 1,000 tissues at their bedside, it's because they have increased production of mucus, which unfortunately has a reverse effect of the nice, thin, protective mucus. It kind of clogs up the airways and makes it difficult for them to breathe. The cilia are paralyzed when you smoke, so the ciliary activity, the sweeping motion of the cilia to help get contaminants out of our airways, stops. And patients who are exposed to nicotine have chronic enhanced inflammation in their airways and their lungs, which is not a good situation because inflammation, as we know, leads to difficulty breathing. It leads to chronic changes in the airways, which makes it harder to breathe. I like this cartoon. I mean, I don't, but I kind of think it's funny. My first vape. So, who's being targeted by so many of these e-cigarettes? Flavors like mango and cotton candy and Fruit Loops, they're targeting kids, right? So the U.S. Surgeon General declared e-cigarette use in youths an epidemic. So they issued an advisory, and they've attempted to have legal sanctions brought against the e-cigarette manufacturers, specifically because they are targeting kids. You don't have to be a genius to realize that Fruit Loops is not a flavor that's typically aimed towards adults, although I like Fruit Loops, but they're definitely targeting kids. So the Food and Drug Administration and the CDC and your state and local health departments are, this was last year, they were looking at e-cigarette product use associated lung injury, and there was actually a kid who ended up having a double lung transplant because he had lung injury related to a preservative in his e-cigarette. These are just some highlights of the advisory from the CDC and the Surgeon General. The flavors might be deleterious to the health of young people. There's moderate evidence that the use of e-cigarettes increases the frequency and intensity of cigarette smoking in the future. Nearly 1 in 5 ever users of e-cigarettes or cannabis had vaporized cannabis with e-cigarettes. So there's a correlation between using an e-cigarette and vaporizing cannabis as well. And we talk about the Juul product because they have 20 regular cigarettes worth of nicotine, and about 2/3 of the users of this product do not realize that the product always contains nicotine. So this is really concerning, right? Because addiction is real. Nicotine is powerfully addicting, and I personally take issue with the fact that young kids who do not understand what they're using are unaware that this product is extremely harmful and extremely addictive. I wish that the 15-year-old having an e-cigarette could see themselves at 40 with lung disease because they're smoking 2 packs a day. And the U.S. Surgeon General advises that parents, teachers, healthcare professionals, and public servants all take immediate action to curb the use of e-cigarettes among young people. Here's that patient. So this patient had crazy inflammation and scarring due to e-cigarettes. The kid vaped, and he was a 16-year-old athlete who ended up intubated and with 2 new lungs. And a lung transplant is no tiny surgery. He's going to have a long recovery process. And this article, if you want to follow the link and check it out, because it's not benign. This is a serious problem. Not only this poor child himself, but the fact that we're having a whole generation of youths who are addicted to nicotine. All right, so here's our case study about COPD. Mr. GS, a 77-year-old guy, he comes to the hospital complaining of shortness of breath. He has a cough in the morning and he has swelling in his lower extremities. He has difficulty breathing when he walks short distances, such as to the bathroom. That's a pretty short distance. So what happens with COPD? You have airflow limitations during exhalation due to the loss of the elasticity of the lungs. So you take in deep breaths and you have difficulty exhaling. There's airflow obstruction that occurs because of mucus hypersecretion, mucosal edema, and bronchospasms. So here is a nice picture of what your normal alveoli look like. They are like little sponges with all those little chambers nice and open and flexible. In emphysema, these little areas break and you have mucus trapping, you have sponges that don't recoil basically. So the air gets trapped inside the alveoli when the patient has emphysema. With chronic bronchitis, which is all part of COPD, remember we don't separate it anymore, but you have this normal, beautiful, open bronchial tube, which is right down here. So there's the trachea and then there's the bronchus come off the trachea. So this is your normal bronchial tube. It's nice, wide open. It's got a little bit of mucus and those cilia are really active, which are keeping the contaminants out of your lungs. And then here we have a bronchial tube affected by bronchitis. You can see it's swollen. The mucosa is very swollen here, and what you can't see is that you have thickened, sticky mucus on the inside of these airways. It's not a good combination. So the patient not only has air trapping in the alveoli, which means the lungs are not able to exhale fully, but you have a narrowing of the airways. So it's a combination of pathophysiology that makes it difficult for these patients to breathe. The primary process of this is inflammation, and it's due to inhalation of noxious particles like smoking. Cellular mediators are released, which cause damage to the lung tissue. The airways become inflamed, and the lung parenchyma, those alveoli, are destroyed. The supporting structures of the lungs are also destroyed. Air goes in easily, but remains in the lungs, and the bronchioles tend to collapse. So it causes a barrel chest look. And this is just another picture of that nice, wide open, normal bronchus here, and then this one that's inflamed. And look at the amount of narrowing in that airway. And this patient is definitely not having an easy time breathing. Is just some more information about the patho. This is from your Mosby book. Talks about the inflammation and the remodeling of the airways and the destruction of the lung parenchyma and vascular changes in the lungs. The pathology includes all these bad things that happen, and eventually it can lead to things like pulmonary hypertension and cor pulmonale, which is in fact heart failure due to your lungs having disease, and there are other systemic effects that can occur. Review the patho of COPD because I don't have enough time to really explain it, but it's important for you to understand what's going on for these patients. So this is just a nice illustration of how air trapping happens. So here's your alveolar walls. This one is larger and the mucus is very thick here and it plugs off the area and your bronchial walls are collapsed. So here's inspiration. You can inspire easily, but then when your bronchial walls collapse and that mucus kind of sticks the area shut, that air can't get out. So it's trapped inside the alveoli. And that's where all your gas exchange happens, right? The alveolar walls are full of capillaries, and that's where your oxygen is taken out of your lungs, and you exhale carbon dioxide. So if this isn't happening, you're not getting good gas exchange, and your breathing is impaired. So those gas exchange abnormalities result in hypoxemia and hypercarbia. So you have not only low oxygen, but you have high CO2 as the disease worsens. As the air trapping worsens and alveoli are destroyed, bullae, which are large air spaces in the lung parenchyma, and blems, which are air spaces adjacent to the lung tissue, can form. So this is a bullae. I can't find my mouse. There it is. So this large open area, it would be considered a bullae. And if you could see a patient's chest wall with a lung, the blems are outside the lungs. They're adjacent to the pleura. And this kind of damage occurs in COPD. So you can see the normal lungs, these alveoli are nice, wide open, like that dry sponge we talked about. With COPD, you have air trapping, the bronchioles lose their shape and become clogged with mucus, that green gross stuff in there, and the alveoli are destroyed, which means that these larger alveoli have fewer areas for gas exchange. So Gias, you're back to our case study. He says he sleeps in a recliner at night to make it easier to breathe. And he says his shoes are tight at the end of the day. He's placed on oxygen at 2 liters per minute via a nasal cannula. What are your priorities for GS? And what will your assessment be? So I'm having you think about that because we're remote. You're going to have to think about, this is your patient. He's telling you he sleeps in a recliner. He needs some oxygen. What are your priorities? And what are you going to do first for assessment? So for COPD patients, remember the pathology, they have chronic airflow limitation. They get tired easy. This guy's tired on his walk to the bathroom. That's pretty easily fatigued. They're at risk for frequent respiratory infections. The assessment of a COPD patient involves, you're going to listen to their lungs, you might hear wheezing, you might hear some bronchi if they're currently having a lot of mucus and have a cough, you might hear nothing. They might have very diminished respiratory sounds because remember, those alveoli are not expanding like they're supposed to be. They can have shortness of breath, also known as dyspnea. They can have a prolonged expiratory time, which often you can use as a therapeutic way for them to help get some of that air out of their lungs, and we'll talk about that in a bit. They usually have increased sputum. You might see his tissues at the bedside. Unfortunately, we also see his cigarette at the bedside with his oxygen on. They may have orthopnea, which means that they have to sit up to breathe. And this is a common posture of your COPD patients, leaning over the bedside table. With COVID patients, they are prone and prone means laying on the stomach, because you get to use those big areas in the back of your lungs, which we don't typically use. We're typically either upright or laying down, like reclining on our backs. But patients with COPD want to use the areas of the lungs where they can, they're leaning forward. So they use those larger areas in the back of the lungs. Cor pulmonale is late in the disease. Usually it is failure of the heart to function well because the lungs are damaged. So your patient talks about swelling of the feet. That could be that he's starting to have some heart failure because of his lung disease. And they can be very thin because they're using all their muscles, all their nutrition to breathe. And they might be having difficulty eating just because it's so hard for them to breathe. Digital clubbing is a change in the fingers that occurs when patients are chronically hypoxic. Okay, so you examine your patient. He has a prolonged expiratory phase, so he breathes in and it takes him a while to breathe out. You hear wheezes, you hear decreased breath sounds. He has an increase in his anterior to posterior diameter, also known as a barrel chest. This is a common physical finding in patients who have lung disease. If you look up Steven Tyler, he has some pretty bad COPD, and he's got a barrel chest. That's a really good example. They want to maintain this tripod position, kind of leaning over the bedside table so they can utilize all of those areas of the lung in the back. And they often will do pursed lip breathing like on their own as a way to help with that expiratory phase. And we'll talk about that a little bit. This is a really good photograph of a COPD patient. You can see they're leaning forward. They're very thin. I would even describe this as cachectic. You can tell that they've been using all of their muscles, all of their energy to breathe. They can have a bluish red color of their skin because they have polycythemia, which is overproduction of red blood cells due to cyanosis. So somebody who has chronic low oxygen, the body is going to develop more red blood cells to try and compensate for that low oxygen, and that's called polycythemia. It's not uncommon to have a COPD patient whose H&H is like, 25 and 53, or, just a high number of red blood cells, and it's a result of their hypoxia. These are different classifications used for COPD, classified as mild, moderate, severe, and very severe. And the gold classifications are 1, 2, 3, and 4. The forced expiratory volume, this is how the patient's COPD is measured. So what is forced expiratory volume? It is you take a breath in and you breathe it out. And if you're breathing out is greater than or equal to 80% of what you should be breathing out, then you have gold level 1 or mild COPD. And this is really, more like a pulmonology approach, but the nurse should know how severe their patient's COPD is when they're treating them, because your expectation of what your patient's able to do will change depending on how, mild, moderate, or severe their lung disease is. So GS has some pulmonary function tests, and he has symptoms of mild to moderate COPD. He says he smoked a pack of cigarettes a day for 30 years, and you're going to want to calculate the patient's pack years, and it's pretty easy. So if he smokes 1 pack a day for 30 years, then it's going to be 30 pack years of smoking. If you have a patient who smoked, a half a pack a day for 20 years, their pack years of smoking is going to be 10. And his history includes heart disease and GERD. So what are some of the complications of COPD? We talked a little bit about cor pulmonale, the heart failure that occurs because of lung disease. Patients can have frequent exacerbations of COPD, where they can have, even the slightest little infection or allergic reaction can cause them to have significant difficulty breathing. These can be treated, typically they're treated with antibiotics, and they can also require steroids sometimes to improve their breathing. Acute respiratory failure, this can occur with patients who have COPD, and here's your patient who's a COPDer who's been intubated and they're on a ventilator. And if you've ever taken care of these chronic patients who have bad COPD who've been intubated multiple times, it's a little disconcerting because that tube goes into the large airway, and it's extremely irritating for most people. Most people require sedation to tolerate an ET tube, but if it's a patient with COPD who's been intubated many times, they can be wide awake, kind of using the suction catheter to clean their mouth out, on their phones, pretty much like with it, but with a breathing tube in. It's once you see that, you won't forget it. And they can also have peptic ulcer disease just because they're having, the chronic stress of not being able to breathe. And many, many patients with COPD suffer from depression and anxiety. And this is one of the things that I saw a lot in my grandma, because she was a very active, very, You know, she never sat still for a minute when she was well, and when she had her COPD progress to the point where she couldn't do what she wanted, it was very depressing for her. She had a really hard time as she lost function in her later years. The other thing that's very common in COPD patients is anxiety, because think about how you feel when you can't breathe. If you've never had that experience, hold your breath, try and hold it for a full minute, and see how you're feeling by the end of that minute. If you pass out, don't sue me, but it's pretty disconcerting to not be able to breathe. Most people who have shortness of breath will have significant anxiety, and for your COPD patients, you're going to want to make sure that you try and allay their anxiety as best you can, while understanding that it is an extremely real feeling for them. So what is a COPD exacerbation? It's usually happens with a change in their usual amount of shortness of breath. They can have increased cough and increased sputum production. Once the patient starts having these COPD exacerbations, it's usually associated with poor outcomes for the patient. The most primary causes of an exacerbation are a bacterial infection or a viral infection. And when you are, the alarm bell should ring when the patient's using their accessory muscles to breathe. If you've not seen this or don't understand what that means, please Google it and have a look at a video. It's pretty profound. If you've had a patient who's using their accessory muscles, they're in distress. And they can also have central cyanosis, which is bluing around the mouth. That also is a sign of concern. You're never going to see your patient using their accessory muscles and turning a little blue and come back and check on them an hour later. That's a phone call, usually to a provider, and you want to make sure that you do everything that you can to help that patient breathe better. Treatment of exacerbations includes antibiotics, short-acting bronchodilators, corticosteroids, and supplemental oxygen therapy. So Gia says he's had attacks like this in the past year, but recently he had one that was a bit worse. He says that he and his wife had visited their daughter. Obviously, this is pre-COVID when people used to visit each other. He visited their daughter and 3 kids who were all sick with cold. So what likely happened? He caught the cold from the kids, and he had a very hard time breathing, because a minor cold for a healthy person can be, a serious event for someone who has pre-existing lung disease. They need rapid treatment, they need antibiotics, and they probably need steroids. These exacerbations, as we just said, they're associated with poor outcomes for these patients. They can be caused by bacterial and viral infections, and if you see a patient using their accessory muscles or with cyanosis, that is a sign that they need help. You treat it with short-acting bronchodilators, corticosteroids, and antibiotics. And they may need an increase in their oxygen therapy. If the patient's on 2 liters, they may need a little more oxygen just to get over the hump. So with COPD patients, they do experience many losses. If a patient becomes anxious because of shortness of breath, you can teach them pursed lip breathing, which they may do automatically just because it's a better way for them to breathe. Anxiolytics can be helpful, so you can use benzodiazepines, but they can depress the respiratory drive, so you want to use them with caution in your COPD patients. So what is pursed lip breathing? It's basically, breathing in through the nose, you're sniffing the flowers, and you count 1, 2, and then you breathe out through the mouth and you count 1, 2, 3, 4. Sometimes when I have a patient who's really anxious and they're breathing really fast, I will put my hand on their belly and I'll say, just breathe right into my hand. We're going to count and breathe together. 1, 2, inhale, and then purse your lips like you're blowing out the candle and count 1, 2, 3, 4 as you exhale. And you may have to stay with your patient for a little while to help them, to regulate their breathing. Because if they breathe fast, that gas exchange is not going to occur. They're going to have more air trapping, and it's just going to make them more hypoxic and more anxious. So we talked a little bit about the forced expiratory volume as a way to diagnose COPD. The patient, if they're concerned that there's a genetic issue happening, they'll do an alpha-1 antitrypsin antibody screening, and that will happen especially if the patient is young when their COPD is diagnosed. You can check an arterial blood gas to see, how much oxygen is actually in the arterial blood. Chest x-rays have pretty common findings for patients with COPD. They have like flattened diaphragms, which are normally like beautiful half moons, but they tend to flatten out in patients who have chronic lung disease. There's something called the COPD assessment test, or CAT. And there's also a modified medical research council dyspnea scale. And oftentimes, if it's a patient's first diagnosis, they'll do a walk test. So the oxygen, the respiratory therapist or the pulmonologist or whoever's doing the test will have the patient walk around to determine the oxygen saturation or lack of it in the blood with exercise. And exercise activity intolerance is a very serious nursing diagnosis for patients with COPD because they typically have a hard time maintaining their oxygenation with any kind of activity. They just don't have any reserve. So your gentleman, GS, having shortness of breath while he's walking to the bathroom, I don't mean he's walking like around the block to get to the bathroom. He's walking probably, maybe 20 feet from his bedroom to the bathroom, and just that little bit of activity makes him short of breath. My grandma, at the end of her life, when she would take a shower, I remember helping her in the shower, and it was a significant effort for her to just sit in the shower chair and get washed up. She would be completely short of breath by the end of it. And then there's something called the Bodin index as well. So when we talk about genetics and COPD, this alpha-1 antitrypsin is a protein that is made by the liver, and it's found in the lungs. Its main function is to protect normal lung tissue from attack during inflammation. So if the patient has alpha antitrypsin deficiency, it leads to premature emphysema because these patients don't make that protein which protects the lung, and they have early destruction of lung tissue. A blood test can determine low levels of alpha antitrypsin. Those who have borderline low levels can then be genetically tested for alpha antitrypsin deficiency, and treatment is IV administered alpha antitrypsin augmentation therapy. So this is not inexpensive, but it can prevent someone from having lung damage because they do not produce this protein. So for a young patient, your takeaway from this slide is, remember, if you have a young patient presenting with COPD, especially if they don't have a smoking or a vaping or a cannabis history, they don't smoke, they're not exposed to any industrial problem, any industrial lung contaminant, it's recommended that they be tested for alpha antitrypsin deficiency. All right, so Mr. GS's arterial blood gases show a slight decrease in his oxygen and a slight increase in his carbon dioxide. His chest x-ray here shows flattening of his diaphragm. So where normally a person's diaphragm would be nice and like half moon shaped, his is kind of on the flatter side. He says that he has difficulty completing his activities of daily living, so taking a shower, brushing his teeth without frequent rest periods. His saturation is 88% on room air, not stellar, right? We want our patients to be like 97 or greater. And his forced vital capacity and his forced expiratory volume, so his forced vital capacity is his inhale, his forced expiratory volume is his exhale. The ratio of those two things is 65%. So he's not doing a great job of getting rid of the air that he inspires. And he says he's having difficulty completing his, I told you that already, ADLs without frequent rest periods. So he's got some, I would say, I don't have the scale in front of me, but he's probably moderate for his COPD. The fact that he needs to rest frequently, the fact that his saturation is low on room air, he's got some COPD going on. So how do these patients get taken care of? There's things that you can do which can make a difference for their health. They have a chronic illness. They're going to have to be careful about how they interact. Like a patient with COPD now during COVID, they would be at high risk for complications if they caught the virus. So they're going to have to self-isolate and be really cautious about what, interaction they have with others. In general, you're going to evaluate for any environmental or occupational irritants, determine ways to control those or avoid them. You're going to have them get the flu vaccine, the pneumovax, and make sure that they get rapid treatment in case of an exacerbation. Quitting smoking is the number one thing that these patients can do to improve their health, to obviously, if somebody's not got COPD, it's the biggest thing they can do to reduce their risk of developing it. And patients who stop smoking, their decline in pulmonary function will slow down to almost non-smoking levels. It's really important to stress quitting smoking. It's a terrible addiction. It's something that is really challenging and difficult to overcome, but there are many resources available, and you can help your patients just by advocating for them. What are the treatment goals for COPD? So you want to improve the patient's ventilation. You want to promote secretion removal in these patients, teach them an effective cough, make sure that they understand how to breathe most effectively. You want to prevent any complications and ultimately progression of COPD symptoms. You want to promote the comfort of your patient and have them participate in their care. You want to improve their quality of life and also prevent and or treat COPD exacerbations. So one of the things that I do recommend highly to patients who have COPD is participating in pulmonary rehab. Any sort of exercise that they can do is going to help relieve their shortness of breath and their fatigue. It's going to improve their emotional function, and it will enhance their sense of control over their conditions. So pulmonary rehab was one of the things that my grandmother really looked forward to. It helped her maintain a pretty good quality of life, I want to say, for the last couple to 3 years of her pretty severe COPD. And of course, this is pre-COVID we're talking about, so she was able to go to the physical therapy center for pulmonary rehab, and she would be in the gym with other people who had COPD. So it was not only good for her physical function, but it was really good for her emotional function as well. She got to see people, with the same illness she had, and they would be able to, share experiences about that. Unfortunately, because of the pandemic, we're not able to do that at this point, but perhaps there may be some sort of remote option available for your patients to keep them active and to keep them participating in their own care. So supplemental oxygen therapy is really important for these patients who are hypoxic at rest. You want to make sure that their O2 sat is greater than 90%. During both rest and sleep and exertion, or if you're monitoring arterial blood gases, which you're probably not unless you're in the acute care setting, you want their PiO2 to be greater than 60 millimeters of mercury. Oxygen delivery systems are high or low flow. The low flow is the most common. It's mixed with room air, and delivery is a little less precise. It's actually a lot less precise than high flow. High flow offers a fixed concentration of oxygen, the Venturi mask. There's also a high flow oxygen system that's used in acute care. These things are not the Venturi, I wouldn't want my patient at home to be on a Venturi mask needing a higher concentration of oxygen. Typically, your patients at home are going to have a nasal cannula, 2, 3, 4 liters, and they're going to be checking their oxygen at periods during the day. If you are not familiar with oxygenation and oxygen therapy methods, go to Kaplan right now, pause this, and review all the videos, all of the skills videos about oxygenation. You need to know if you're giving your patient, 2 liters via nasal cannula, how do you hook that up? How do you make sure your patient's safe? I once was called into a room by a nurse who was freaking out because their patient was desatting, and the oxygen was on the mask was on the patient's face and totally unplugged from the wall. So remember, you have to check the whole system, make sure it's connected, make sure the oxygen's turned on, make sure it's not connected to medical air, make sure it's on the green oxygen wall thing, and check the whole system. When you go to clinical this semester, hopefully you'll have some patients who need oxygen therapy, and you'll be able to go over them with your clinical instructor. So humidification is used commonly. These little wall bubblers can be attached to the oxygen cannula. It's used because the oxygen has a drying effect on the mucosa. It's supplied by nebulizers, vapotherm, and then these little bubble-through humidifiers. What are some complications of oxygen therapy? Obviously, it's flammable. That's why we have the no smoking sign. We don't want our smoking patients to have, oxygen that explodes. Patients who are getting high levels of oxygen are at risk for oxygen toxicity. It is not a benign treatment. Patients can have atelectasis because of the oxygen, which atelectasis means the lung parenchyma are like sticking together, and patients can be at risk for infection as well. CO2 narcosis is a specific incidence, which I think we're going to talk about in the next slide. Yes, so CO2 narcosis. COPD patients, sometimes their physiology will change and they'll have chronically increased carbon dioxide. They also can be known as carbon dioxide retainers, CO2 retainers. They don't respond to hypercapnia as their respiratory drive. So you or I, we hold our breath for a minute. The reason why we want to take a deep breath in is because our CO2 rises. It is not because our oxygen's low. Our oxygen's not low in like 1 minute, but that CO2 rises and we need to breathe to get rid of it. That's a normal person's respiratory function. Chronically ill patients with lung disease can have accommodated themselves to a higher level of CO2. So they have chronically increased CO2 in their ABGs. So if I take a patient's ABG and their CO2 is 52, 54, normal level is 35 to 45, I'm like, oh, they're a little bit elevated, but that's probably where they live. Their oxygen might also be low. Their SAT might be kind of hanging in the 90s on 2 liters, and that also might be where they live. I would suspect that these patients have a hypoxic drive to breathe, which means they need to have their oxygen at a low level before their respiratory drive kicks in. It's not the CO2 being elevated that's causing them to breathe. It's the oxygen being decreased. It's called a hypoxic drive to breathe. So if I take my grandma who needs to have an oxygen level of 84 to take a breath, and I put her on a 100% non-rebreather mask, she's not going to breathe. It's really important to know that high levels of supplemental oxygen can lead to respiratory depression, unconsciousness, and even death. Do not just put a bunch of oxygen on your patient because their oxygen level is low. It is not a benign intervention. I cannot stress that enough. This is why you need a provider order to put oxygen on your patient. It is not benign. Do not crank it up for no reason, because you could cause your patient to have a decreased respiratory drive. They could stop breathing and become unconscious. There are many different drugs used for COPD. Bronchodilators are probably some of the most common ones. They relax the smooth muscles in the airway. They improve ventilation of the lungs. They decrease your dyspnea, and they can increase your forced expiratory volume. The inhaled route is preferred. Now, buterol is very common. You can also have anticholinergics and methylxanthines. There's some other medications, long-acting anticholinergic, like Spiriva, which is a little capsule that goes in a little handyhaler, it's called, and you crush the capsule and breathe it in. If you have to administer Spiriva to your patient, make sure it is inhaled and they don't take it, like, by mouth. Patients can also take inhaled corticosteroids. And antibiotics are commonly used. Zithromax is pretty broad coverage. That's used a lot for COPD exacerbation. There's also daily resp, which is a phosphodiesterase inhibitor. It kind of works on the inflammatory process in COPD. And then it's also common to see combinations of drugs like Combivent, which is ipratropium, which is like a drying agent, along with albuterol, a bronchodilator. So your patients' medication regimes are usually pretty individualized, but include some or all of these different drugs. So Mr. GS is given a short-acting bronchodilator via a nebulizer. So he also is given this short-acting beta agonist inhaler and an incentive spirometer for home use. So here we go. We have this inhaler right over here, and then here's your incentive spirometer. He's also started on Zithromax because, remember, he went and visited his daughter with their 3 kids and probably has a little bit of a bacterial pneumonia going on. So he's going to get Zithromax for that. So what about patients that need oxygen at home? The data shows that long-term oxygen therapy at home will improve the patient's prognosis, it improves their mental acuity, and it improves their exercise intolerance. It also reduces the hematocrit. Remember the polycythemia that happens because patients are chronically hypoxic. If you take away that chronic hypoxia, they don't have to produce all those extra red blood cells. It can also reduce pulmonary hypertension. And periodic reevaluations are necessary to determine the duration of use. But here's a gentleman comfortably relaxing at home with his concentrator beside him. Respiratory! So, love your respiratory therapist. Depending on where you work in the hospital, you may or may not become friends with respiratory. In the ICU, respiratory, were my best buds because my ventilator patients needed a lot of respiratory care. The respiratory therapists knew the ventilators a lot more than I did when I first started there as a nurse, and they're often able to troubleshoot issues with oxygenation because they're specialists in that area. So remember, when you have respiratory therapy involved, be their friends in the hospital. Be kind to your colleagues. So also physical therapy can be really helpful, especially for your patients with COPD who need breathing retraining and help with effective coughing and help with their activity intolerance too. So physical therapy may be able to take your patient for a walk with the oxygen on them and offer them, frequent rest periods, show them how they, recover after a little bit of walk, and just generally be helpful. Your colleagues in the hospital can really make a difference for your patients with COPD. And remember, it is a team approach. It should be a team approach. Different things that you can do to help your patient expire all that mucus. You can use chest physiotherapy, or the respiratory therapist can do this. It includes percussion and vibration and postural drainage, so you can put your patients, if they can tolerate it, you can put their legs up at night and help them to get some of that mucus up. Percussion and vibration, I would demonstrate if we were in lecture, but please, look it up in your book. Make sure you understand what is going on with CPT. And there's little devices that you can use your patients that are having difficulty clearing their mucus. There are things called an acapella or a flutter device. It kind of looks like an avocado, and you have your patient breathe into it, and it causes a little sound. My dog hates it when my husband used this after surgery, but it basically shakes the airways a little bit and helps the patient expel their mucus. So take a look at some of these things online if you haven't seen them in practice. Oh, this is a beautiful picture of what your hand looks like when you're doing chest physiotherapy. So you make your hands in a cup-like position to create an air pocket, and you are going to go along the patient's back. And you're going to help shake that mucus up. It will facilitate movement of thick mucus. It can be done with a bed. Sometimes you can put a little motor on the bed and it will shake. It's really loud. And sometimes the patients like it and sometimes they don't. You're never going to percuss over bony or painful areas. You're not going to percuss someone's kidney. If they've had surgery, you're going to stay away from that area, and you're not going to percuss their spine. It's really over the lung areas that you're going to do this. We talked about patients with COPD having pretty significant weight loss. They can be very malnourished. The pressure on a diaphragm from a full stomach can make it hard for them to breathe, and they may have a hard time breathing during a meal. So you're going to make sure the patient is rested before a meal. You're going to give them their inhaler. You can try and keep them on oxygen. If they can use a nasal cannula while they're eating, that might be helpful. Have them prepare 5 or 6 small meals to avoid bloating and early satiety, and avoid foods that require a great deal of chewing. Avoid exercises and treatments 1 hour before and after eating. Avoid gas-forming foods, and a high-calorie, high-protein diet is recommended. And also a high fluid intake of greater than 3 liters a day should be taken between meals. So this is a challenge for your patients with COPD. Sometimes your COPD patients cannot tolerate a big meal. There have been some studies that show that high carbohydrate meals are not good for patients with COPD because it can make their metabolic situation a little worse. So you're going to make sure that they eat their protein foods first. I try and offer like an Ensure or milkshake for a snack, because sometimes they can drink things easier than they can chew and swallow them. So what are some of the nursing diagnoses for COPD? Ineffective airway clearance, impaired gas exchange, imbalanced nutrition, less than body requirements, risk for infection, insomnia. That's a big one. So what are the goals for your patient? You want to prevent progression of that disease. You want them to be able to perform their activities of daily living. And you want to give them some relief from their symptoms. You want to try and avoid complications related to COPD, exacerbations, infections, hypoxia, cor pulmonale. You want to improve their knowledge and their ability to implement long-term regimens. So you want to make sure these patients can stay safely at home and care for themselves. And overall, you want to try and improve their quality of life. So Mr. GS is going to be discharged home. He's given the little acapella there, the little avocado looking thing. It's going to assist him with expulsion of mucus. His wife is present, and you begin to teach them about home care. What areas could be addressed with GS in regards to health promotion, and how can his wife and family help? So you want to make sure he's not smoking. You want to have him quit smoking. You want to give him a stop smoking counselor, the patch, the Chantix, the whatever you can to try and get this gentleman to quit smoking. You want to control their environmental irritants or pollutants and see if they can be avoided. You want to show him what he needs to know for exacerbations, so you can detect that early and treat it. And make sure that he understands the signs and symptoms of a respiratory tract infection so that he can get treatment for that quickly as well. So Mr. GS comes into the clinic in a week for follow-up. He's breathing much easier and says that he's able to perform his activities activities of daily living with less distress. And he and his wife ask about how to prevent further breathing difficulties. So what are your goals for this patient? You want to make sure that they're breathing without. I would recommend pulmonary rehab for this gentleman. Make sure that he understands how helpful that can be. Again, because of COVID, that may not be a possibility, but it might be something that can be done via Zoom. Exercise training will lead to energy conservation, and it may improve muscle function and reduce his difficulty breathing. When you teach these patients about exercise, make sure they understand that their shortness of breath should return to baseline about 5 minutes after exercise. Teach them to modify the ADLs to conserve energy. Bring a chair in front of the sink if that's what you need to do to brush your teeth without having to stand up. Walk 15 to 20 minutes a day, at least 3 times a week with gradual increases, and make sure they understand how important rest is. If they're having signs and symptoms of pneumonia, heart failure, acute respiratory failure, they should be seen rapidly. Make sure they understand the the effects that they should be assessed for. Patients with insomnia because of COPD can really have a hard time. There are many reasons that patients can have challenging sleep routines. They can be taking medications that cause their heart rate to race, or they are awake because they've had albuterol right before bed. They can have postnasal drip or coughing that keeps them awake. Encourage them to, they can use nasal saline sprays or decongestants, or sometimes a nasal steroid inhaler like fluticasone can help them if they have a significant postnasal drip or cough before bed. A lot of these patients will sleep in recliners. What are your expected outcomes for your patients with COPD? Normal breath sounds, effective coughing, have them clear that mucus, return of the oxygen to normal range for the patient. And remember, these patients have chronic respiratory illness, so you're not going to expect them to be 100% on room air. Make sure you ask the patient, do you wear oxygen at home? What's your normal O2 sat? Because many of them can tell you. You can get a little O2 monitor on Amazon for like $15, and it can tell you exactly what your heart rate and your O2 sat is. Most of these patients are used to monitoring their oxygen. Improved mental status, oftentimes confusion or agitation is one of the early signs of hypoxia. If I have a patient who was like awake and alert and oriented at the beginning of my shift, and now they're, looking delirious and not making sense, I'm going to check their oxygen and listen to their breath sounds, because that's usually one of the earliest signs of low oxygen is poor mental status. You're going to teach them how to eat and maximize their nutrition for a normal body weight. You're going to follow their nutrition labs and make sure their protein is adequate. Help them improve their sleep with a better sleep routine, possibly medications for postnasal drip, possibly like postural changes, like they may need 4 pillows to sleep well. You want to make sure that they're rested. You want to help them prevent any infection. Don't, go visit the daughter if the 3 kids are sick with colds. And have them understand fever, increased shortness of breath, low oxygen despite supplemental oxygenation, worsening swelling, or any symptom really that's concerning to them. They should call their provider and seek medical attention, because early assessment and treatment of these issues can help with better outcomes. And that's all I got. Thank you.